Hello, everybody. Reed here again. So, let me give it a few minutes to let a few more people to get in before I start talking. Just give it a few minutes. I'm happy that you're getting a chance to watch this today. It's the highlight of my day. Um, Today, we're going to have a very interesting discussion. Uh, it's going to be on vascular dementia. We went through Alzheimer's dementia, Parkinson's dementia, Huntington's dementia, frontotemporal lobe dementia, Lewy body dementia. And now we're going to look at vascular dementia. Vascular dementia is a very complicated type of dementia to fix, to manage. Why? Because it has to do with blood vessel destruction, right? Strokes. So strokes produce vascular dementias. Two type of strokes. The vessel can pop and the blood can ooze out, hemorrhagic, or the boulder inside of the vessel can get occluded, and it's an occlusion, and so there's no more blood distal to the occlusion, and the occlusion is I forgot the name of stroke, not hemorrhagic, but embolic stroke, right? And I think it's important to understand the differences between the two, because you can imagine the treatment would be different. If you have a blood vessel oozing blood, I'm sure that's a different treatment modality than a blood vessel obstructed. But I'm a psychiatrist, and I'll leave that to the other guys to worry about. What we want to know is the impact that stroke is having on the person's ability to function. We're going to look at several things: memory, attention, concentration, executive functioning, abstract reasoning. We'll look at all those things when we try to characterize how severe this type of stroke is. And also, we're going to need to look at those things when we have to come up with a plan on exactly what we're going to do. Now, this is a very, very important area to be there for the patients when they have these types of events, because time is brain cells, right? We need to handle that right away. We need to get the blood supply back. We need to sort of stabilize those areas, right? Now, I'm on Google here. So let me see. Let me start off with the brain vessels. Let me see. Brain arteries. Okay. Which one? Try this one. Try this one. No. Let me go back to this one. I'm trying to do all the free stuff. Let me review this again. Great. Remember we looked at the temporal lobe, right? Remember the frontal lobe, temporal lobe here, Broca's area, sort of language, sort of interpretation of things, Remember temporal lobe seizures and epilepsy, rage, is temporal lobe connected very closely to the amygdala. So the amygdala gives it a lot of meaning and things like that. So this is where the fits of rage can come in. This frontal lobe, and we wanted to that prefrontal cortex, this area around here, this seat of abstract reasoning, right? It doesn't really show the prefrontal cortex here, and it's hard to really show a line demarcating the prefrontal cortex because it's only the area. If you probe the prefrontal cortex, it does not result in any type of muscular movement, right? And then we have the frontal lobe here, which is the seat of our executive functioning. So look at all the different points of all the different points where something can go wrong. If you get something like an occlusion here or something like that in this main truck, it'll cut off the supply to all the tributaries downstream. If you get obstruction distal, then hopefully it wouldn't be severe, right? Let's see here. So this is what we're talking about here. So a vascular dementia is when one of these vessels become occluded or pop, and it results in destruction and damage to the tissue around it. Now, this destruction results in inflammation. And remember, inflammation is the enemy. Well, inflammation is not the enemy. Inflammation is the process that sort of try to restore balance here. But what's happened is in order for the inflammation to sort of restore balance, it has to make the blood-brain barrier porous. So you go from a semi-permeable membrane to a membrane with huge gaps in it. And what happens? All the content gets into the CFS and it interferes with the functioning of all the networking around it, right? So vascular dementias are very serious, and you have to take them very seriously and do a very thorough evaluation because it can involve a lot of different domains. Remember, up here, the executive functioning domain, so they can exist in a state called executive dysfunction, meaning no purposeful behavior, right? No attention, concentration, difficulty organizing, sequencing, things like that. So you'll see the cognitive decline, a diminution SORM, lack of awareness of environment. You start to see all these things, right? If it involves more of the prefrontal cortex, then they lose access to abstract reasoning, right? They become very concrete. Abstract reasoning means it's hard for them to put the little pieces together and see what it makes, right? Assemble all the pieces to a toy car comes in the box, right? So if you're concrete, you'll just see pieces of a car. You probably wouldn't know that you can assemble all the pieces together and you will have one car. 30 pieces make one car. Look at those pieces. Oh, that's one car. That's abstract reasoning. That's because of the processing that happens in the prefrontal cortex. Now, when strokes affect that area of the brain, the prefrontal cortex, of course, it's also the seat of working memory, right? So you get abstract reasoning, but working memory is your capacity to hold all of those items into your memory until you're able to do some type of computation. But you have to hold all the things in your memory before you sort of rearrange them and try and see what this is, rearrange the blocks and the objects to sort of see what this is, right? But if your prefrontal cortex is damaged because of the stroke, then the person will be concrete and lack abstract reasoning. Here's the question I use to sort of test for that. What does it mean when I say people who live in glass houses should not throw stones? What does that mean? People who live in glass houses should not throw stones. Why? The stone would break the glass. That's concrete. Why? Because the stone would break the glass, Dr. Reed. That's why people who live in glass houses should not throw stones. So you see the deficit of abstract reasoning, you think, wow, man, I think this stroke is affecting the prefrontal cortex. If they couldn't pay attention or concentrate or anything like that, then you would think about more of the frontal lobe here. Executive, if they're making impulsive decisions, decisions that behavior that's unusual or not typical, and also here in this frontal lobe, you also have the seat of more of your personality, right? How do you handle your interpersonal relationships and things like that? So patients with hemorrhagic and embolic strokes can have significant personality changes. Remember frontal temporal lobe dementia? Remember the temporal area, the rage and the behavior disturbances, and the frontal lobe, the cognitive, attention, concentration services. Anything damage that lobe, it's not going to perform the function it was designed for, it was created for, it developed for, or evolved for. from. Um, let's look at another. Okay, if it involves the deeper structures, here, look at this basilar artery. The deeper structures here. If it involves the deeper structures here, then this is this area where there's hippocampus and things like that. The hippocampus and the temporal lobe up in here. If it involves this, it can damage the hippocampus, and the hippocampus is where you encode information about the environment. If you damage the arterial supply to the hippocampus, then again, inflammation. Inflammation is dangerous for information, is disruptive for these tissues and their functionality. You know, it's just, I guess, it's just like being on the highway when they have to actually shut some of the lanes down in order to make the repairs, right? You know, inflammation is something like that. You know, you need to make these repairs, so you have to bring in all the heavy equipment to do it. But while you're making those repairs, the whole thing doesn't really function well. I don't think anyone wants to go to work when their commute times increase by 2 hours, right? Well, in this case, you're not going to get as much blood supply in that area, and the inflammation is going to cause a lot of dysfunction in the hippocampus, meaning there's a risk. If it's too severe, there's a risk that a person can be on read-only mode. You know what read-only means? You can't add anything to the network. You can just read. When you say read, you can just look and see what the person's doing, but you can't, if you communicate with them, they'll, yeah. They understand everything. They understand that, well, yeah. But then they simply won't remember it. Why? Because it's not going to get encoded on the hippocampus. If it's not going to be coded inside the networks and their memory, then it will not be processed as an experience. You only process things that are in the network, not outside of it, right? If an object has 10 pieces to it and your hippocampus can only code 2, when it goes to your information goes to your prefrontal cortex and things like that, you render a reality based upon the 2 items in your memory, not the other 8 that were never encoded. You got me? So the strokes people can present with very significant and severe memory problems. And we have to test for that. One of the ways we test for that is to test memory, right? You test a person's memory. Let's see. I think that's clear. Let's see. So let me go here. So let me go ahead and look up vascular dementia. Explain vascular dementia. Okay. Remember we went through like the different receptors and the different networks. I think you're going to really need to rely on that conceptual understanding of those networks in order to think your way through these type of problems. Because you're going to have to test the different parts yourself. And if you know how these networks are regulated, then you have a good idea of what class and categories of medications to use. Once you drill down on the category of medications and look at the different receptor profiles and things like that, and then see which one, you think will match up best for this. Some of the patients may require more potent antipsychotics, more potent medications. Some of them may not. Some of them may require medications that's more stimulating, right? So you have to in order to sort of provide just very good and detailed care for these patients, you have to tailor your treatment plan to exactly what's fitting their scenario and their situation, And it's an intellectual exercise to do, but it's very rewarding when you get it right, because you can see a change right away, right? The networks may become destabilized and may malfunction because of the stroke. And if it's a hemorrhagic stroke, then you have blood in the CNS. Blood in the CNS? What? The cerebrospinal fluid is the I think it's holy water, right? Cerebrospinal fluid got to be the holy water because your system, the nervous system is suspended in it, right? The vessel pops and all the blood starts gushing out, and that's toxic. That's too much for this system. So you can see how the blood itself causes other problems. And how are you going to get all that stuff out? And where is it all going to go? Right? I mean, I think the body's going to have a difficult time, a challenging time trying to clean all that up in order to get things functioning well. And then how are you going to get the inflammation? I mean, what happens with the inflammation? You know, vascular dementia sets up a situation where the tissue damage, the hemorrhagic strokes, and even the embolic strokes causes chronic inflammation. Chronic inflammation creates the same challenges that we spoke about before, right? Chronically with a diminishing storm, chronically with a lack of awareness environment, inattentive, difficulty focusing, unable to, very easily distracted, and things like that, can't really think much, and then you may see things like apathy sit in, decreased interest, decreased motivation, right? And so those are some of the changes that could result from the chronic inflammation secondary to a stroke. So we'll explain vascular dementia. Let's do this. Vascular dementia. Okay. A cognitive decline caused by damage to the blood vessels in the brain. That's it. In a lecture, y'all. Blood is reduced or interrupted. Brain cell death and cognitive impairment, more than just cognitive impairment, right? The impairment in mood, impairment in perception, right? Impairment in movement, like move your body, movement, things like that. Left-sided weakness, right-sided weakness, paralysis. So it leads to all sorts of things. Cognitive changes are just the one we talked about. Stroke, small vessel disease. I only mentioned one. Stroke, blockage, or rupture. Right. Look, small vessel disease. Narrowing or blockage of small vessels in the brain. Atherosclerotic plaques. Build up of plaques on the arterial walls, which can block the blood flow. Let me explain this. This combination, high blood pressure. Prolonged high blood pressure can damage vessels in the brain. Patients with diabetes, atherosclerotic plaques, prolonged, very poorly controlled high blood pressure, and or some type of substance abuse like cocaine, which causes vasoconstriction. And the moment the vasoconstriction can occur up to hour, 10, 12, 15 hours. And that's going to significantly reduce the blood supply to those regions of the brain. You get like hypoxic brain injuries from the decrease in the oxygenation of those tissues. They become significantly injured. When those tissues become injured, what happens to the networks? They don't just fail, they become overactive. There's no regulation. They become overactive, then become underactive and overactive, and that's all they do, flicker on and off like that. And that's what happens to the tissues that's damaged downstream from these embolic events. People having strokes after using cocaine, right? That's another risk factor for vascular dementias. Look at this pathophysiology here. The buildup of the cholesterol plaques, right? Let me show you this. Let me see, show me the build. Y'all figure I can't type. I can't type and look at the same time. Okay. All right. There's an interesting story here A very interesting story. I think this is it. Oh, I think this is a better one here. Yep, I think it's better. Okay. Okay, let me show you this. This narrowing increases, you get a decrease, increased pressure. What is it? Virility laws. Decreased pressure. If it's a decreased circumference, the rate of the blood flow quickens in this area. When this plaque becomes too encrusted, it can develop flakes or parts where it's not homogeneous, right? This pumping can cause a plaque to break off, and then it goes downstream, right? Then it goes downstream. And these emboli are sort of like microscopic particles, sort of like very small grains of salt. And they go all the way down. They keep going until they're so small. They keep going until they block the very smallest arteries, right? And this thing is going on all the time with these cholesterol plaques. And let me show you if it happens in the comet carotid. Let me see if I can get some images of it in the comet carotid so you can see how serious this is. And sometimes we have to get a Doppler, right, to look to see how much is occluded or not. Here's the common carotid right here, right? And then here's the bifurcation from the internal carotid artery and the external carotid artery here. This area right here, yeah. This massage, like chiropractic massages and stuff like that. Other things that can cause dislodging of these plaques, and it goes downstream. And you can see if there is a embolic stroke, if it's large enough, it can block a huge tributary. So this is what we're talking about there. So here, this is the atherosclerotic plaques. And again, if you have narrowing or blockage, okay, look, blockage of small vessels in the brain. This is the process what I'm talking about. See, this atherosclerotic plaques actually creates a small vessel disease, and it shows up as, like, I think punctate lesions on a CT scan. I got a lacunar infarct on a CT scan, something like that. Let me review that part. But I showed that it does show up on a CT scan. If someone knows the answer, I think it shows up as lacunar infarcts. I said, okay, but the small vessel disease primarily could be significantly created by all of these small emboli that are breaking off from this atherosclerotic plaque. And of course, if you have very poorly controlled high blood pressure, of course, it's going to speed that process up. Now, if this is the distribution, these arteries are the distribution, is this the field to assess? This is going to be a doozy trying to look at the symptoms, because they come from almost anywhere, right? Of course, memory loss, hippocampal, right? Hippocampus function, difficulty with problem solving, decision making, right? Frontal lobe impairment, right? Confusion and disorientation, hippocampal failure, right? If your hippocampus isn't encoding any information, you're not updating anything from your environment. So when your reality renders your reality, you believe it's real because it is real. Nothing's wrong. It's just that your reality, you don't have any information included about the environment. Everybody else in the environment is integrating the information. So they have one world, and there's the person with the difficulty, they live in a different world, and they're in the two worlds. And let me tell you, the two don't meet. They don't fit together well, right? The ones with the higher capacity always have to adjust at the level of the person they're in and engage on that level. And you have to be respectful when you do that, right? So that's the confusion, disorientation, hippocampal dysfunction, slow processing speed, right? Frontal lobe and things, frontal lobe and the parietal lobe. Look, changes in mood and personality, mood, temporal lobe, that frontal lobe, right? Temporal lobe, rage, right? And personality, that frontal lobe, right? Difficulty with language and communication, temporal lobe, right? Walking problems and fall, basal ganglia, right? So that stroke, after you got to do a really good physical exam on a stroke, because you get a chance to see all the different parts that it's impacting. And what you're going to have to do, what? Know the networking of each of those parts. Pick your tools. You're going to have to find a way to put this system back together again. Next is treatment, managing the underlying risk factor, lowering blood pressure, quit smoking, medications to improve blood flow, cognitive rehab therapy, supportive daily living. And so the treatments seem to make sense, don't they? Okay. The prognosis for vascular dementia depends on the severity of the damage and the underlying risk factors where the stroke took place, right? I'm reading this, even though my pen is over here, my red. I think I should go over this way. At least I'm looking this way. Okay. At least I'm looking towards the document. All right. Additional, this is the second most common type of dementia after Alzheimer's. Right. The second most type after Alzheimer's. It affects people of all ages, more common in adults. No cure, right? Treatment can manage the effects. So here's the brain, and then you can see how certain tributaries and things like that. Okay, a normal blood vessel. Oh, blood vessels with dementia? No, they could not blood vessels with dementia. It's not a good source here. With dementia. Okay, I don't think I need anything else. Let me see. And of course, the medication, I don't think I need to go on the medications because they're going to be dependent on what you look at. Okay. And what you want to, okay. So I think that's it. I don't think I need to cover anything else with vascular dementia. Okay. So let me see if I can ask get a few questions in. Okay, guys. And then we're at 27 minutes. So I don't want it to go on too long here. Hey, Moeen, how's it going, buddy? Thanks for the questions. What makes vascular dementia different from Alzheimer's dementia? Remember, Alzheimer's damage to the hippocampus. It's the acetylcholine muscarinic acetylcholine network. Remember, inside those cells in the hippocampus, they have the buildup of intracellular inclusion bodies called those tau proteins, and this is the waste, the intracellular waste. It builds up to the point where it can dislocate the whole cell body. This huge mound of waste destroys the brain cell. The brain cell dies, right? So it's a gradual buildup of debris inside the brain cell, so resulting in brain cell death. And it's a gradual transition. So it only affects the memory, right? Whereas vascular dementia, the strokes everywhere potentially, right? Okay, next, TJM. Hey, TJM, how's it going? Okay, what role do strokes and mini strokes play in vascular dementia? The strokes would be the huge ones that block arteries, but those mini strokes are the small microscopic cholesterol plaques that goes down, and it goes down and includes the very small blood vessels. And so the pathology at that point is at the end of the vascular tree at the smallest level, whereas the other embolic events may include whole trunks, things like that. So the location of the location where the pathology presents itself is different. Okay, I think that's all I need to do for today. It's been a pleasure, and I hope this has been very helpful for you guys. If this is interesting to you, please like, subscribe, and share. And I'm going to continue to add these do these presentations. So it's a pleasure. Next, I want you to look through the video on the mesocortical pathway, also on the hippocampus, for the acetylcholine muscular network and the frontal lobe. And then I think once you review those, this vascular dementia and how you treat it, particularly if you view the networks, then you understand the network and you sort of understand how to select your medication with these. It's a pleasure. And until again, I'll see you guys later. Read out. Take care, guys. Ciao.